Okay. Good evening and welcome everybody to this webinar, online webinar by in the name of Pudukkottai Badan, ISA Pudukkottai branch. I welcome and invite our Secretary, Dr. M. Periyasamy, to go for the welcome address. Over to Dr. Periyasamy.
Thank you, sir. Thank you, sir. I'm audible?
Yes, yes.
Yes. Yeah, audible?
Yes, yes, yes.
Okay, thank you, thank you, thank you.
Listen in one.
Hello.
Light is also at least.
Dr. Periyasamy, your voice is breaking. Dr. Periyasamy, your voice is breaking. Dr. Suresh Kumar, sir, you can take over.
Yeah. Respected Secretary, Pudukkottai ISA branch, our academic chairman, Dr. A.L.M. sir, treasurer, Dr. David, today's chairperson, Dr. Debendra Kumar Tirupati sir from Rishikesh. Our speakers for session 1, Professor Dr. Gurudat sir from JSS Medical College,
Hello.
Mysore. Speakers of session 2, Dr. Girish, Associate Professor from JSS Medical College, Mysore. Resident Dr. Sri Lakshmi from same college, Mysore. To assembled the postgraduates, practicing anesthesiologists, members of ISA Pudukkottai and brother branches from India. I welcome you all for this 14th edition of our online weekly academic program, Pudukkottai Budan. At the outset, this is our 14th edition. We have completed more than 3 months of academic activity continuously, non-stop, with so many topics useful for the practicing anesthesiologists as well as postgraduates in particular. We have inculcated at the biggest of our academic chairman a resident speaker every week, so that they will able to prepare well, able to have a chance to have a talk in this webinar. It will be very useful for their future. Today's topic is very nice because often we will face this failed spinal program, and Dr. Girish will tackle that. And on and off, you may have encountered this post-dural puncture headache in our practice when we will be called for managing the Pdph after 4 or 5 days of our anesthesia day. And our resident Dr. Sri Lakshmi will throw light on this. And our Professor Sir Gurudat will continue the part 2 of the last week's talk regarding anesthesia workstation, pressure regulators to common gas outlet. Today's academic webinar will be very useful for all of us I again request all of you to join in the name instead of the mobile uh, device name, and please make use of that credit hours we have incalculated, medical council credit hours also, and please take active part in the chat post lecture so that you can discuss all the doubts and other things. I invite our academic chairman, Dr. A.L.M. sir, to conduct the further proceedings. Over to Dr. A.L.M. sir.
Thank you, sir. Dr. Periyasamy, whether your internet
Yes,
is
sir, I'm audible.
your internet
Okay,
is
okay.
Yeah, please. Proceed.
Yes, sir, yes, sir.
Dr. Periyasamy, I think you are having a problem. Dr. Periyasamy, you can stop the slide share. Dr. Periyasamy. So there is a hiccup from the secretary side. So we are taking over the session. At the outset, I welcome the President, Secretary and the Treasurer of Pudukkottai ISA City Branch, and the speakers today, Chairperson Dr. Devendra Kumar Tripathi, and Dr. Gurudat from JSS Mysore, Dr. Girish from JSS Mysore, and Dr. Sri Lakshmi. So, as you know, Dr. Gurudat become the first person to represent in this successively. That is a second performance for him. And we know everything about Gurudat sir. Last week itself, we have discussed about him in length. He is a star speaker. And today he has promised whenever there is a problem in finding a speaker at that particular moment, or if an accepted speaker could not perform on that particular day, he volunteered to be a replacement. So we thank you very much, sir, for your kind consideration. Thank you very much. And that shows his dedication in teaching. And he is showing the postgraduates to come up in life. So he is a guide also for them, because only JSS Mysore interns, that is residents, have represented frequently in this webinar. The credit goes to Dr. Gurudat sir, HOD of JSS Mysore. And we have the second speaker today, Dr. Girish. Dr. Girish is a postgraduate. He has graduated from Stanley Medical College as an anesthesiologist. So we are happy that he is from our own state, and he is interested in obstetric anesthesia and pediatric anesthesia. So for the past 10 years, he is working in JSS Mysore. So when he is marked by Dr. Gurudat, that shows his credibility. And Dr. Sri Lakshmi had done his her undergraduation from Kerala, and she is now a resident in JSS Mysore. So today we have a good combination of Dr. Gurudat from Karnataka, Dr. Girish, a postgraduate from Stanley, Tamil Nadu, and Dr. Sri Lakshmi from Kerala, and the chairperson, Dr. Devendra Kumar Tripathi, is from Rishikesh. So our chairperson, peculiarly today, he is an additional professor in All India Institute of Medical Sciences, Rishikesh. He was known as a Pudukkottai man. He has organized the conference in 2013, and he was working in Indira Gandhi Medical College, Pondicherry. He was a treasurer, secretary, and vice president of ISA Pudukkottai, and sir has devised a ICU ventilator, Pranavayu. Am I right, Dr. Tripathi sir? It is so he has devised his own ventilator, and he is having 4 patented products for his own, and he is having more than 30 international and national publications to his credit. We all know COVID has done so much of bad thing for the entire society, but it has done one good thing. It has given some clarity, and it has thrown light on Dr. Devendra Kumar Tripathi, that he was a crisis management team, and he has obtained a special certificate. He was awarded for the COVID management. So he is interested, and he was a ex-vice dean for academics in All India Institute of Medical Sciences, Rishikesh. We are happy to have him, and he has agreed to deliver a lecture on lower limb blocks for Pudukkottai Budan, because he is interested in regional nerve blocks. So with this introduction, I hand over the podium to Dr. Devendra Kumar Tripathi, chairperson for this session. Thank you, sir.
Thank you, sir. Thank you, sir, for such a kind introduction. And I am really pleased to be part of this program. And I'm really thankful, Dr. El sir, for asking me to join this. And without delay, I just ask Professor Gurudat sir to start the topic. And everybody knows about him, so he doesn't need any introduction from anybody. Sir, please start, sir.
Thank you, sir. I'll just share my screen. Okay, good evening, everybody. First of all, I would like to thank the Pudukkottai Budan and the organizers, Dr. Suresh Kumar, Dr. Periyaswamy, and especially Dr. A.L. Meenakshi Sundaram for this opportunity that has been given to me again. You know, last week also I was here in this podium, and again this week also. I think I'm the first person, that's what Dr. A.L.M. was talking about, that opportunity has been given for me again twice. So thank you so much. And also I would like to thank Dr. Tripathi, is the chairperson for today, for introducing me for this session. So I would like to bring greetings from JSS Hospital and Medical College, where I am presently working. You know, last week, last Wednesday, I was speaking about the anesthesia machine and the workstation. And we all know that, you know, the anesthesia workstation has got mainly a pneumatic component and then the electrical and electronic component. And most of the time in the exam, because, you know, this particular lecture is mainly concentrating on the postgraduates. So because, you know, most of the questions are asked regarding the pneumatic component. And I was discussing you about the pneumatic component of the anesthesia workstation. And we all know that this pneumatic component of the anesthesia workstation is classified based on the amount of pressures that are there in each of the system. So we have the high pressure system, where it is the cylinder pressures. It is from the cylinders up to the pressure regulators, we have the high pressure system. From the pressure regulators up to the flow control valve, we have the intermediate pressure system, where the pressures are, you know, roughly about 50 to 60 psig of the pipeline pressure, and the pressure that is reduced from the pressure regulator of the cylinders to 45 psig. And in the low pressure system, it is from the flow control valve to the common gas outlet. So it is just above the atmospheric pressure, maybe about 78 pounds per square inch. In my last lecture, I discussed in detail about the cylinders, then you know, the yoke assembly, then the pressure gauges. Up to the pressure gauges I had discussed. So this lecture, I'm going to discuss from the pressure regulator up to the common gas outlet. Now coming to the pressure regulators, I'm just showing you the pressure regulators, how they look like when you just open the lid of the Boyle's Basic or the Boyle's Mark III anesthesia machines. So you just open the lid and you can see the regulators. Why I'm showing you this for pictures of the anesthesia pressure regulators here is, many times we'll be asking you to just show the pressure regulators in the exam from the anesthesia machines, and you will not be able to show this because you would not never had lifted the lid and then seen these pressure regulators. Of course, in modern anesthesia workstations, everything is covered, nothing is seen. So, but you should always know about these pressure regulators that are there in the older machine. These pressure regulators are also there in the modern workstations, but hidden inside. You can see here on the right side, I am showing you the picture of the pressure regulators of nitrous oxide. On my left side, I am showing the pressure regulators of oxygen. So why I am just keeping these both, that there is a difference between these pressure regulators of nitrous and oxygen. So on the nitrous oxide pressure regulator, which I am showing, so it has got 3 chambers here, unlike the oxygen pressure regulator, which has got only 2 chambers. So there is a connection of oxygen is also there for the nitrous oxide pressure regulators. This is mainly, the nitrous oxide pressure regulator acts as a slave regulator to the oxygen. So oxygen pressure has to be there to open the nitrous oxide flow. So that I'll be discussing in detail in my next lecture, in my coming, following in the same lecture, slightly later. Now these pressure regulators, you have 2 kinds of pressure regulator. One is a primary or the first stage pressure regulators. These first stage pressure regulators or primary pressure regulators are basically present so upstream of the yoke assembly and just between the yoke assembly and the flow control or flow meter assembly in most of the anesthesia machines, and in the workstations. So just before the fail-safe valves, the primary pressure regulators or first stage pressure regulators are there. So in case of GE machines, so we do have the second stage pressure regulators are also there. These pressure second stage pressure regulators in GE machines are there just upstream of the flow control or flow meter assembly. So let us discuss about these pressure regulators, the primary pressure regulators. These primary pressure regulators convert the high pressure of the cylinders of 750 psig of nitrous oxide and 2000 psig of oxygen to 45 psig that enters into the intermediate pressure system. So one question is commonly asked is, what are the functions of a pressure regulator, or why a pressure regulator has to be there? So just imagine that there are no pressure regulators. So that means you have opened the oxygen cylinders and the nitrous oxide cylinders, and directly that amount of high pressure gases are flowing into the anesthesia machine. So you have set a flow of say 3 or 4 liters of oxygen. Just imagine that there are no pressure regulators in between the cylinders and in the flow meters. I have set a flow of about 3 or 4 liters. And what will happen after say 5 or 10 minutes? Once the cylinder starts getting used up, the pressure inside the cylinder also starts falling. So this 3 liter of flow or 4 liter of flow of oxygen, whatever that is I have set, is at a pressure maybe of 2000 psig. After sometimes once the pressure starts coming down, the flow of oxygen in the flow meters also starts coming down. So my job will become only to keep on adjusting the flows, because every 5 to 10 minutes, the pressure inside the cylinder falls and then the flow also starts falling. So I'll not be able to concentrate on the patient and other things in the operation theaters. My concentration has to be on the flow meter itself. So in order to prevent that, most important function of the pressure regulator is to provide a constant pressure and flow of gases to the flow meters. Just I was telling you about, suppose if I introduce a pressure regulator in between the cylinder and then the flow meters. So the cylinder pressure is now reduced to 45 psig. Till the pressure in the system is reduced to 45 psig and below, the flow, whatever I've set in the flow meters, will not alter. So this is the most important thing about the function of the pressure regulator, why a pressure regulator has to be there. The second most important function of the pressure regulator is that high pressure gases, if they directly enter, may produce wear and tear of the fine needle valves of the flow meters, and also they can damage the other finer the equipment inside or the machine that are there inside. That also is prevented by the pressure regulator. The third thing is, it prevents the barotrauma for the patients. So majority of the times what we have found is when we ask the student what is the function of a pressure regulator, directly they say preventing the barotrauma of the patient. It is the least function of the pressure regulator. Main function is to maintain a constant flow of gases to the flow meters. So this is very important. Now the next thing is, and the other common question you'll be asked is, what is the principle on which these pressure regulators are constructed? How they operate, how they reduce the pressure from high pressure to a very low pressure. So this is based on a basic principle, that is force is equal to pressure into area. Suppose if we keep the force constant, so and we increase the area, automatically the pressure has to drop. So this is a basic principle under which the pressure regulators are constructed. I am showing you a simple diagram of a pressure regulator. Here you can see a spring force is there. This is a very high force that is always kept constant. Now if the gases from the cylinder are passed through a smaller chamber next to a larger chamber, once they enter a larger chamber and now they encounter a large surface area of the diaphragm, so automatically, because the area is increased, the pressure automatically has to drop, provided the force is kept constant. So here the force applied is very high and it is always kept constant. So the outlet pressure always remain low. In spite of the cylinder pressure starts dropping also, the outlet pressure will not change much because of the high pressure that is present in this spring that is being applied. And these pressure regulators are also called as the fixed pressure regulators. Many times the short notes is always asked regarding the fixed pressure regulators. So these fixed pressure regulators are called as fixed pressure regulators because whatever the outlet low pressure is fixed by the company itself. You cannot alter it. That's why it is called as a fixed pressure regulators. Now coming to, I was talking to you about the master slave pressure regulator. So in Boyle's Mark III and also in case of the Boyle's Basic, so these master and slave pressure regulators were introduced. And you can see here, I was talking to you about the nitrous oxide pressure regulator having 3 chambers. So the first chamber, second chamber, and third chamber, you can see the oxygen connection to the first chamber. So from the third chamber, the nitrous oxide has to get released. So it is only because of the oxygen pressure being applied in the first chamber, so the nitrous oxide can flow out. So if there is no oxygen pressure in the first chamber, the nitrous oxide is just cut off. So the nitrous oxide cannot flow out. So the nitrous oxide pressure regulator acts as a slave regulator to the oxygen pressure here. That's why oxygen is a master and the slave is the nitrous oxide pressure regulator. I'm just showing you a diagrammatic representation of this master and slave pressure regulator. You can see this is the top chamber, chamber 1, which I showed in the photograph. So this chamber is the one wherein the oxygen is entering here. So this for chamber 1 is separated from the chamber 2 by a diaphragm. Now we can see the diaphragm here. So and again, the chamber 2 is separated from chamber 3 by again another diaphragm. So these 2 diaphragms are connected by a spring in between. So what is happening here is, the nitrous oxide has to flow through the inlet here, and then it has to enter into the chamber 3. So as long as the oxygen pressure is there in the chamber 1, it is going to depress the diaphragm between the chamber 1 and 2. In turn, the spring gets activated. It is going to depress the diaphragm between the chamber 2 and 3. That in turn is going to depress this valve thrust pin. Once the valve thrust pin is depressed, the nitrous oxide can flow into the chamber 3 and can flow out. So this is how the master-slave mechanism works. Suppose if there is no oxygen pressure, so if the oxygen pressure is not there, so the valve thrust pin will totally block the flow of nitrous oxide into the chamber 3, and there won't be any outlet of the nitrous oxide. So that's how the master and slave mechanism work. So in modern workstations, we don't have this pressure regulators acting like master and slave mechanisms. What we have, these master and slave systems have been replaced by the fail-safe valves. So in modern workstations, we have the fail-safe valve. So when they introduced this master and slave system, along with the Boyle's Basic and Mark III, many of the people thought that now we will not be able to provide hypoxic gas mixture to the patient, but they were wrong. Still, you can one can provide hypoxic gas mixture to the patient. I'll just show you the photograph here. So in this photograph, I'm showing you that I am opened only the nitrous oxide. Here in this machine, there is master and slave mechanism is there. So, but you are not giving, I'm not giving any oxygen, but still you can give nitrous oxide provided the oxygen pressure is there inside. I have opened the oxygen either pipeline or the cylinder. Then as long as the oxygen pressure is there, I can still give only nitrous oxide through the flow meters. So I'll just demonstrate this. Many times you'll be asked to demonstrate this master and slave mechanism in the exam. I'll show you a video of this, how the master and slave mechanism will work.
Voice basic machine, I just want to demonstrate you how the master and...
Just let me know, are you able to hear the voice of in this video?
Slave mechanism of the pressure regulator. Regulator to oxygen, I just demonstrate. Now,
okay.
What I am doing is I am opening oxygen. So oxygen flow is there, oxygen pressure is there through the nitrous oxide pressure regulator because I have opened the oxygen cylinder. Now I have kept both oxygen and nitrous oxide. You see, I can open nitrous oxide now. So what I will do is now I will close the nitrous oxide oxygen cylinder. That means there won't be any pressure of oxygen to open up nitrous oxide. So the nitrous oxide also should fall down. So what I will do is I am just closing down the cylinder of oxygen. Now there is no oxygen flow. I will remove whatever the oxygen is there in the piping by pressing the flush. Now you can see nitrous oxide is also falling. Now I am trying to open only nitrous oxide, so I will not be able to open the nitrous oxide. So what I am going to do now is, again I will open oxygen. Now I have opened oxygen. So once I have opened oxygen, the problem with the fail-safe systems or the pressure slave regulator system of the older machine and also the fail-safe valves of the newer workstations. The newer workstations, we have fail-safe valves which have just replaced the master-slave mechanism that was there in the older machine. These are also almost like master-slave only. The oxygen pressure has to be there to open the fail-safe valve of the nitrous oxide. So no, but with this, though they are called as fail-safe valve, they are not actually the fail-safe. I'll just demonstrate with this. So now oxygen is, I've opened the oxygen cylinder. Now oxygen pressure is there, which is passing through the nitrous oxide regulator, and it has opened the nitrous oxide pressure regulator. With this, I can still give only nitrous oxide. See, now I have opened up only nitrous oxide. I can still give the patient only nitrous oxide and without oxygen, and definitely that is going to produce quite a bit of hypoxia. So in order to prevent that, what we have is the proportionating devices that are there at the flow meter level, so that I am going to discuss later. Voice basic machine.
The high pressure system, just at the last part of the high pressure system was the pressure regulators. I have just completed the high pressure system. Let us move on to the intermediate pressure system. So in the intermediate pressure system, we have the pipeline connections. So you can see here oxygen pipeline connection and also the nitrous oxide pipeline connection. So these pipelines, so they enter into the intermediate system because there is a separate connections and there are separate inlets on the back of the workstations for the connection of these pipelines. So they have a pressure of roughly 55 to 60 psig, and the connections are also diameter indexed things are there. So this diameter index safety system or NIST non-interchangeable safety, non-interchangeable screw threading is there. So these things were in detail discussed in my last lecture. So I'm not going to discuss much about this pipeline supply that is in part of the intermediate pressure system. So the other parts of the intermediate pressure system, you have the fail-safe valves, you have oxygen supply failure alarm, the oxygen, the second stage pressure regulators, and then the oxygen flush valve. So let us discuss these things independently. So first thing, let me discuss about the fail-safe valve. Already I told you about these fail-safe valves which have replaced the master and slave pressure regulators of oxygen and nitrous oxide. So in the newer workstations, you have a separate fail-safe valve. The oxygen pressure has to enter into the fail-safe valve of nitrous oxide to open the the nitrous oxide flow into the flow meter assembly. So these are the fail-safe valves. They are present mainly just downstream of the primary pressure regulators and upstream of second stage pressure regulators in GE machines and upstream of flow meter assembly in the Draeger machines, because in the Draeger machines we don't have the second stage pressure regulators. So these fail-safe valves are again depending on the workstation, whether we have a GE machine or whether we have a Draeger machine, they're slightly different. So let me just discuss about these fail-safe valves of GE and Draeger machines. In GE machines, they are called as oxygen failure sensor shut-off valves. That means they are all or none. Either the flow of nitrous oxide is there or flow of nitrous oxide is cut off at a particular critical pressure of oxygen. Whereas in Draeger workstations, what we have is oxygen failure protection devices. So they are slightly different. Let me discuss about the shut-off valves first, that is present in the GE workstations. So in the GE workstation, you can see here, oxygen, as long as the oxygen pressure entering into this fail-safe valve is more than 25 psi. So, the thrust pin is going to push the valve away from the flow of nitrous oxide, and the nitrous oxide can easily flow out of this fail-safe valve. So once the pressure of the oxygen falls to less than 25 psig, so thrust pin will come down and totally close the valve. So once the valve is closed, there is no flow of nitrous oxide out of this fail-safe valve. So nitrous oxide flow is just cut off. So this is an all or none thing. That means till above 25 psig of oxygen pressure, nitrous oxide will be flowing out. You can still use nitrous oxide, but if the pressure of oxygen falls less than 25 psig, you'll not be able to use nitrous oxide, but you can still continue to use oxygen. So that is the shut-off valves. Now coming to the oxygen failure protection devices that are there in majority of the Draeger workstations. So how they work? Now slightly different when compared to the shut-off valves. Now here you can see this diagram. So the oxygen pressure is oxygen is entering with a pressure of 50 psig. This is pushing a piston and preventing a nozzle away from the nitrous oxide tubing or nitrous oxide flow. So as long as the pressure is oxygen pressure is above 50 psig, this nozzle keeps away, and there is a complete continuous flow of nitrous oxide of equal to 50 psig. So let us see, once the pressure of oxygen starts decreasing. So here I have shown you that 25 psig. What will happen is the piston starts coming down. With that, the nozzle also will start coming down. So this nozzle partially obstructs the tube that the nitrous oxide is flowing through which. And once there is a narrowing of this tube, we all know that the Bernoulli's principle, where when the gas encounters a narrowing through a tube, so there the pressure drops and the velocity increases. Here that is the same thing occurs. The pressure also proportionately comes down to 25 psig of nitrous oxide. So once the oxygen pressure drops, and if the oxygen pressure drops down to 10 or less than 10 psig, this nozzle comes down completely down and totally obstruct the flow. That means the flow completely shuts off at 10 psig in OFPD, that is oxygen failure protection device. That's a slight difference in the oxygen fail-safe valves between GE machines and the Draeger machines you should always be knowing about. Coming to the oxygen supply failure alarm, another component of the intermediate system, pressure system. Now we know that as per the machine standards, when oxygen supply pressure falls below a threshold of usually about 30 pounds per square inch, a medium priority alarm shall blow within 5 seconds. So this is the machine standards. So in older machines, what we had was the pneumatic alarms. So these pneumatic alarms were introduced in Boyle's Basic and also Mark III. So these pneumatic alarms were actually the Bauman's or Ritchie whistle. So when the oxygen is connected to the machine, a pressurized canister, usually used to be a canister, separate canister inside the anesthesia machine. So this canister was connected to these, whistle. And as soon as you put on oxygen or connect the source of oxygen, either cylinder or the pipeline, this canister will fill with oxygen. And as long as the pressure of oxygen is higher than a particular pressure, So this canister is not in turn communicated or connected to the Ritchie vessel. So once the oxygen pressure falls below a certain value, the alarm directs the stream of oxygen from the canister through the vessel, and then the vessel start blowing. I'll just show you diagrammatic representation. So this is the canister I was talking to you about, and this canister is actually separated from the vessel by the, a seat is there and the spring is there. So because the pressure of oxygen that is flowing into the canister is high, it is also pushing the seat and then blocking the vessel from getting communicated with the oxygen source in the canister. So once the oxygen pressure falls, the spring pushes the seat away, and there is a direct communication between the canister and then the vessels will start blowing. So that's how, once the vessel starts blowing, then you know that the oxygen pressure has come down to less than 30 psig, then you will have to open a backup cylinder. So the disadvantage with this pneumatic or the vessel system purely by the pneumatic component was that this vessel will stop once the oxygen in the canister finishes. So it is not going to continue, because the machine standard says that the vessel should continue till as another source of oxygen is opened up. So that is one problem with this pneumatic type of alarms. The second one was, people thought that this oxygen, maybe about 20 or 30 liters that is collected inside the canister, should have been used for the patient and not for activating the vessel. So because of these, later in Boyle's Mark III and the Boyle's Basic itself, so electronic alarms were introduced. So you can see this electronic alarm in the Boyle's Basic, and they have these being operated by cells. So you had to check every time before you start using this anesthesia machine whether the cells are active or not. Otherwise, you have to replace the battery. So whereas in case of modern workstations, we don't have to replace this battery. It is electrical connection is there, and we have the electronic alarm systems are there because we have the pressure sensors, and which will immediately sense what is the pressure, continuously will be sensing what is the oxygen pressures. And once in GE machines, once the pressure comes down to 28 psig or less, so automatically the alarm will start off. And in Draeger, once the pressure drops down to less than 30 or 37 psig, the alarm will get activated. And these alarms, based on the standards, it will continue till the oxygen pressure is restored. That's about the electronic alarms that are present in the modern workstations. Coming to the another component, that is the oxygen flush. So you should recognize the oxygen flush here by O2 plus. That is how you can easily recognize. So as soon as you press this button, so 35 to 70 liters of oxygen will start flowing out of the common gas outlet. So one thing you should also remember that this oxygen flush valve is directly connected to the pipeline source or if you're having a cylinders, so directly to the pressure regulator. That means the amount of pressure is same as the pressure of the pipeline system or the pressure regulator, that is 45 psig or 60 psig. The oxygen will be flowing through the flush valve once you activate this flush valve. Another thing you can see in this figure, so the flush valve, the oxygen will directly flow to the common gas outlet. So it is going to bypass the flow meter assembly, and also it's going to bypass the vaporizers. So because of this, so high pressured gases are being provided to the patient. So it can produce either dilution of gases, one of the problem, because it is bypassing the vaporizers and then the flow meter. So there can be lighter planes of anesthesia if you accidentally open these flush valve, or it can also produce barotrauma. So that is the problem. But why a flush valve has to be there? This flush valve, oxygen flush, is there since ages. It is not only present in modern workstations. It was there from the beginning of the introduction of the anesthesia machine. So what is the the function of this oxygen flush when we are going to use this oxygen flush? So especially when you are ventilating a patient with a mask and you are finding difficulty in mask ventilation because of various causes. So then there is so much of leak around the face and then the mask. Then you activate the flush so that you overcome this leak by extra amount of oxygen, that is almost nearly 35 to 70 liters of oxygen that is flowing. So that's how one of the functions of the oxygen flush. It's a safety mechanism that is present in all the machines and the workstations. So you can definitely use when you are finding difficulty in mask ventilation, or suppose if you want to give 100% oxygen under higher pressure to the patient, then also you can activate the flush. So the other time when you use this oxygen flush is when you are checking for the positive pressure leak test. So when you want to check for the positive pressure leak test, so then also you can definitely use the oxygen flush. So you can pressurize the whole system with the by activating the flush. So the other time when you use this oxygen flush is to check for the integrity of the inner tube of the vein circuit. So we all know that the Pathics test. So when we are using this Pathic test, so we also use the oxygen flush. So I was telling you about the accidentally, if you activate the oxygen flush, so 35 to 70 liters of oxygen with high pressure can go to the patient and can produce barotrauma. But this also has been thought about in case of Draeger machines. What we have is, we have the decoupling valve. So because of the presence of this decoupling valve, so what happens is the fresh gas flow during inspiration is not directly, the fresh gases cannot enter into the inspiratory limb of the circle system. So here you can see here, so because the Draeger machines, the ventilator is a piston driven ventilator. So here, this is the inspiration. So the positive pressure is created in the inspiratory limb. And because the positive pressure is created, so the decoupling valve, which is now separating the fresh gas flow from the inspiratory limb, is closed because of the positive pressure. So because it is closed, even all the fresh gases are entering into the bag. So even if you activate the flush, so it's going to, all the gases are going to they enter into the bag, and the barotrauma is prevented because the fresh gases cannot directly enter the inspiratory limb during inspiration in Draeger machine. So during expiration, what will happen is the piston of the ventilator will come down. So a negative pressure is created in the chamber. Now the expiratory gases as well as the fresh gases are taken by the chamber of the piston driven ventilator because of the negative pressure that is created. Again, during the next inspiration, so when the piston moves, a positive pressure is created, decoupling valve will separate the fresh gases from inspiration or inspiratory limb of the patient. That's how, in Draeger machine, we have the protective protection even if you accidentally activate the flush valve, and when you are using the closed system with the ventilator. And also in case of GE machines, you have the pressure relief valves. They get activated, they just open up because the maximum pressure is always set in the advanced GE machines. So they produce an outlet for the gases to go out, so that we can definitely prevent barotrauma even if you activate accidentally the flush valve. So coming to the second stage pressure regulator, which are again the components of the intermediate pressure system. So these second stage pressure regulators are present only in GE machines. They are not there in the Draeger machines. So in GE machines, these second stage pressure regulators are present just downstream of failsafe valve and upstream of the flow control, the flow meter assembly. So you can see here, so these second stage pressure regulator further reduces the pressure of oxygen to 14 psig and the nitrous oxide of the outlet pressure to 26 psig. That means, why the second stage pressure regulators are introduced in case of the GE machines is that till the pressure in the system is reduced to less than 14 psig, so the flow of oxygen will not alter. Then that means very, very accurate flow will be there, because there can be many times a lot of fluctuations can occur in the pressures of the pipeline as well as the the cylinders. So whenever there can be a fluctuation, even it can be up to 20%, the flow in the flow meters will not alter because of the second stage pressure regulators that are there in the GE machines. So another important thing is because of that, they maintain an accurate flow. And the second, the most important thing I just showed you here, the pressures in nitrous oxide is slightly higher. It is almost double the oxygen pressures. So that means they have a ratio of 1:2 ratio here. So this is going to help the Link 25 system in order to maintain a 3:1 ratio between nitrous oxide and oxygen. That is the proportionating devices that are present in GE machines that I'm going to discuss later. So that is also the second stage pressure regulators also help in maintaining that the 3:1 ratio between nitrous oxide and oxygen. So the Link 25 is almost purely mechanical, almost 95% it is mechanical. Some amount of the pneumatic component is also there because of the second stage pressure regulators. Whereas in Draeger machines, there are no second stage pressure regulators, but still the pressure is reduced before the flow of gases into the flow meter assembly. So that is by the flow restrictors. Though this flow restrictor is a misnomer, actually the nomenclature should have been the pressure restrictor. Here they use the Bernoulli's principle. Already I just discussed about the Bernoulli's principle. When a gas encounters, when passing through a tube, encounters a narrowing. So at that narrowing, what happens is the pressure drops and then the velocity increases. So the same principle has been adopted in Draeger machines. These flow restrictors are there just downstream of the flow control valves. So you can see this tubing has been narrowed here. So at this, the pressure is decreasing and the velocity is increasing. So the flow of gases to the flow meter assembly will be with a reduced pressure. So in Draeger machines, instead of the second stage pressure regulators, we have what is called as a flow restrictors. So the advantage of these flow restrictors in Draeger machines is that they have replaced the second stage pressure regulator, and also definitely they have reduced the cost. The second thing is you should also know that there is some amount of disadvantage because of the absence of second stage pressure regulator, because any sudden fluctuation in the pipeline pressure can also reduce the pressure distal to the restrictors and can decrease the flow. That is always there with slight fluctuation of the pressures in the system. There can be slight alteration in the flow in Draeger machines, which is not there with the GE machines. Now coming to one of the other questions that will be asked for you is how many connections are there to the oxygen supply source? So because many times you'll be asked this, I just wanted to add this also. In the different connections of oxygen either to the pipeline of oxygen or the cylinder of oxygen is for directly for the one connection is to the flow meters, the second connection is to the fail-safe valve. So the number 2 connection, fail-safe valve of nitrous oxide, and you have the third connection to the oxygen supply failure. The alarms are there. Then again, auxiliary oxygen flow meters. So this is not present in every workstation. In advanced workstations like ISIS CS2, we do have auxiliary oxygen flow meters. So this can be used even when you are not operating the master switch, and directly you can provide supplementary oxygen to the patient. So this is again an oxygen connection is there. That is the 4th connection. The 5th connection is to the oxygen flush, and the 6th connection in case of GE machines to the ventilator as a driving gas. Because in GE machines, the ventilator what we have is a bellows ventilator. It is a double circuit ventilator wherein you require a driving gas also. So the oxygen is used as a driving gas for the driving the fresh gases that are collected in the bellows in GE machines. So this 6th connection is not there in Draeger, because in Draeger we have a piston driven ventilator. We don't have a bellows ventilator. So you can always say there are 6 connections for oxygen supply source. Coming to the low pressure circuit. So this low pressure circuit, it extends from the flow control valves up to the common gas outlet. We have this low pressure circuit. The pressure inside the low pressure circuit is just around 7 or 8 pounds per square inch. So the main components of the low pressure circuit is the flow meter assembly. You have the back bar to which the vaporizers are connected, have the check valve, and then the common gas outlet. So let me discuss about the individual components. Let me discuss about the flow meters. Now the flow meter assembly, you have seen in many of the anesthesia older machines. We have the flow meters, and each gas has got a single flow meter in the older machines. So with this single flow meter, there used to be a lot of difficulty in maintaining accurate flows for low flow anesthesia technique. So for that, what we have presently have 2 flow meters for each gas in modern workstations. Because 2 flow meters are there, a separate flow meter up to 1 liter for low flows. So you can accurately even set for the low flows, and for higher flows, you can use the second flow meter. They are in series, so it's a continuation of gases. So that's how in modern workstations, we have 2 flow meters for each gas. The other thing you can also see, just these are the flow control knobs. So just above the flow control knobs, you have a protection here. So this is a guard, so that accidentally the flow control knobs should not be rotated. So the other safety system that are there in the flow meter assembly. So these are the flow control knobs. Again, you should always know that these flow control knobs are color coded and touch coded. So this is another thing that you will be asked in the exam. So because you can see here the oxygen flow control knob is the largest one when compared to the nitrous oxide and air, and it is cylindrical in shape, whereas these two are conical in shape. The third thing is the flutes that are there, they are widely placed and the large with oxygen. So you can just, even without seeing the flow control knob, you just touch the flow control knob, you should be knowing that you are touching an oxygen or the other flow control knobs. So immediately after the flow control knobs, what we have is the proportionating devices. That's what I was talking to you about. The fail-safe valves are not actually fail-safe. That is the reason you required a proportionating devices in the flow meter assembly. So these flow proportionating devices are again depending on what is the workstation you have, whether you have a GE workstation or whether you have a Draeger workstation. So in GE machines, what we have, the proportionating device is the Link 25. So whereas in case of Draeger machine, we have the older name was oxygen ratio monitor control, and now presently it is called as sensitive oxygen ratio controller. So the Link 25 is basically, it's almost 95%, it's a mechanical one, just about 5% pneumatic, whereas the oxygen ratio monitor control or sensitive oxygen ratio control is purely pneumatic. So with these proportionating devices, so minimum flow of oxygen will always be more than 25% of the total flows. You cannot give less than 25% of oxygen compared to the total flows with these proportionating devices. These are also called as the hypoxic guards. So you should always, many times the hypoxic guards have been asked as the short notes. So let me just discuss about this Link 25 first. So you can see this, this Link 25 is mainly, it is present just, distal to the flow control knobs and before the flow control valves. You have sprockets, separate sprockets for oxygen and sprockets for nitrous oxide. The oxygen sprockets are 29 in number and the nitrous oxide sprockets are about 15 in number. That means if you rotate the nitrous oxide flow control knob 2 times, the oxygen flow control knob will rotate by once. That means a ratio of 2:1 between nitrous oxide and oxygen will be maintained. So, and another thing you should always remember, the link between the chain establishes a link between the sprockets of oxygen and nitrous oxide only when the total flow of oxygen reduces to 25% of the total flows. So the link, because it gets established when the oxygen percentage comes down to 25%, this system is called as the Link 25 system. So I'll just show you with a diagrammatic representation of this. You can see here, so these are the sprockets of oxygen having 29 teeth. These are sprockets of nitrous oxide having 15 teeth. So I told you 2 rotations of nitrous oxide will rotate the oxygen by once, but that will maintain a ratio of nitrous oxide to oxygen as 2:1. But I told you that the second stage pressure regulators also reduce the pressures of oxygen to 14 and nitrous oxide to 26 psit. So again, there is a 1:2 change in the pressures of the oxygen and nitrous oxide entering here. So that completes the 3:1 ratio between the nitrous oxide and oxygen. So another thing about you should always know is that the needle valves, so the nitrous oxide needle valve has less taper, whereas the oxygen needle valve has got more taper. That means the amount of oxygen entering into the flow meter itself is slightly less when compared to the amount of nitrous oxide entering into the flow meter. So that's how the 3:1 ratio between nitrous oxide and oxygen is completed. That means minimum oxygen you can always give is 25%. So many times you'll be asked to know how do you recognize this link 25 system in the system. I'm going to tell you in a video. So let me just also discuss about the pneumatic system of oxygen ratio monitor control, or SORC, of the Draeger. So you can see this is the pneumatic oxygen ratio monitor control diagram. So you can see the flow meters. This side is oxygen flow meter. The other side we have the nitrous oxide flow meter. In both the oxygen and nitrous oxide flow meters, we have the diaphragm. We have a resistor. And this resistor in the oxygen flow meter is a stronger resistor, and the nitrous oxide side, it's a weaker resistor. So these flow meters are also connected to the two chambers. One is the oxygen chamber, another is a nitrous oxide chamber. So both these chambers also have the diaphragms, and these diaphragms are connected by a shaft. So once you open oxygen, what will happen is, so the oxygen flows into this oxygen chamber. Because the pressure of the oxygen chamber here, the shaft is pushed towards the nitrous oxide, and the nitrous oxide slave control valve will open, and then only the nitrous oxide starts flowing into the flow meter. And this proportion of minimum of 25% is always maintained. So you try to increase the nitrous oxide, so the shaft starts moving towards oxygen, and the nitrous oxide flow automatically starts reducing. So that's how the proportionating device of the ORMC will work. So you can see here the diagram below. The oxygen flow, we have stopped the oxygen flow, so you cannot open nitrous oxide. So that's how you can easily differentiate between whether it's a link 25 or it's ORMC. Link 25, as you start opening only, you should start opening the nitrous oxide flow control knob. Once you start opening the nitrous oxide flow control knob in link 25, so the oxygen flow control knob also rotates. So whereas in case of ORMC, if you try to open nitrous oxide, no flow will come. So I'll just demonstrate with this video for you so that you can understand what system of the proportionating device you have.
What happens is in the exam, you'll be asked to demonstrate the hypoxic guard or the proportionating devices. You may have a GE machine or you may have a Draeger machine, and you all know that in the GE machine what we have is the link 25, it is a purely mechanical one, and in Draeger machine what we have is the ORMC or the oxygen ratio monitor control, or sometimes it is also called as SORC, sensitive oxygen ratio control. So how to differentiate a particular workstation has got the link 25 or it has got the SORC type of hypoxic guard. So it's a very easy thing. I'll just demonstrate you how to know that whether it is link 25 or not, because GE machine has got link 25. So what you have to do is you just have to rotate the nitrous oxide flow control knob. So when you rotate the nitrous oxide flow control knob, if the flow control knob of oxygen also rotates, then it is link 25, because you cannot open only nitrous oxide because there is hypoxic guard is there. So once you try to open the nitrous oxide, the link gets established between the nitrous oxide and then the oxygen sprockets. So oxygen flow control knob also rotates. Now I'll demonstrate now. You can see here the nitrous oxide is also the oxygen is also rotating. Oxygen is also rotating. You can see both the oxygen and nitrous oxide are the flowing in the flow meter assembly. You can see here it's about the oxygen is about 2 liters and then the nitrous oxide is about 5 liters. That means 25% of oxygen is always delivered. Now what I can, if I just close the nitrous oxide alone will close, oxygen will remain like that, and I can also give only oxygen. When I am giving only oxygen, nitrous oxide flow control knob will not rotate. So this is what is the link 25. So again, in order to know whether it is link 25 or ORMC, just rotate the nitrous oxide knob. So if oxygen rotates, it is link 25. So let us also see how in the dragger machine, how the SORC or ORMC will function, how to detect whether it is SORC or not. So now I'll be demonstrating this is the dragger Fabius Plus machine. So in this you can see here it is written as SORC, sensitive oxygen ratio control. In the older name nomenclature for this was ORMC, or oxygen ratio monitor control. This oxygen ratio monitor control or SORC is purely pneumatic in dragger when compared to the mechanical in GE machines, that is a link 25. So how to identify whether it is SORC is there or not? So you try to open nitrous oxide. So if you try to open nitrous oxide, no flow comes, no oxygen, no nitrous oxide will come if it is SORC, because the oxygen has to flow into the nitrous oxide side to open the nitrous oxide in SORC. So that's how the nitrous oxide will not be coming out when you are rotating only the nitrous oxide knob. Unlike in link 25, when you rotate the nitrous oxide knob, automatically the oxygen knob also rotates because they are mechanically linked. Here I can still give only oxygen I can give, so then the nitrous oxide will not flow. Now I have opened oxygen. Now if I open nitrous oxide, I can definitely provide nitrous oxide. So again now what I'll do is I'll cut off oxygen, so automatically the nitrous oxide also gets cut. And if I try to open again only nitrous oxide, I'll not be able to open nitrous oxide. This is what is the sensitive oxygen ratio.
So, in modern workstations like ISIS CS square machine, or even in Draeger primers, so everything is electronic thing. So electronically controlled hypoxic guard will be there. Suppose if there is any, by chance, this electronically controlled hypoxic guard fails, so then also you can use there the mechanically you can open up the alternate source of oxygen, that is called as an alternate oxygen. So you can see here there is alternate oxygen in GE machines. So the ISIS CS square. So you can just put on this and you can still give the oxygen, 100% oxygen to the patient with up to the 10 liters. You can also provide the vapor also, that is the anesthetic vapor also along with that. So you can definitely, even though the electronic hypoxic guard fails, then you can definitely use this. So in the modern workstations, we do have the electronic hypoxic guard because the flow sensors are there. They always accurately provide the oxygen of more than 25%. So in the ISIS CS square machine also we have, I was talking about the auxiliary source of oxygen. So this is an extra source of oxygen also is there. Even suppose if a whole thing is not functioning, the whole of the electronic system is not functioning, you can still connect your open circuit to this auxiliary source of oxygen, and you can still ventilate the patient without producing any hypoxia. So that is additional safety features that are adopted in modern workstations. Coming to the flow meters, now the flow meter assembly and the flow meters. So these flow meters, you can see the flow meter here, and these flow meters are tapered down, and as you go up, the area of the flow meter starts increasing. So that means the space between this bobbin, the space between the bobbin and the inner wall of the flow meter keeps on changing, that varying annular space. That's why it is called as variable orificial flow meter as well. Now, many times you'll be asked the question of why it has to be tapered. So this has to be tapered mainly to reduce the length or height of these flow meters. So because in order to reduce the height only, the flow meters are tapered. So these flow meters are called as Tharpe tubes. They are made of the very hard glass, which is called as a plexiglass. Usually it will not break. So because of made of very hard plexiglass. So another very important thing, you should also know that, so outside the flow meter and inside the flow meter, it is sprayed with a chemical called as Croxtine. So that is mainly to prevent static electricity. You know, when the bobbin rotates, the rotation of the bobbin will induce electricity there. So once the electricity is released, that electricity, if it stays there, if it becomes static, so it makes the bobbin to stick to the inner wall of the flow meter. Once the bobbin is stuck, you don't know what is the flow of gases. So in order to prevent that, the Croxtine is sprayed inside. So this is another exam question. Sometimes you'll be asked, you should be knowing about. And the other thing is, these flow meters are calibrated for the individual gases, because each gas has got its own viscosity and density. So based on that viscosity and density, so the calibration is always done for the individual gas for the same flow meter. So you cannot, suppose if the nitrous oxide flow meter is broken, you cannot exchange it with a oxygen flow meter, because that is calibrated only for oxygen and not for nitrous oxide. And another thing you should always remember, this calibration of this flow meter is done at the sea level, that is 760 millimeters environmental pressure, and at 20 degrees, that is the room temperature. So the other thing about that, these flow meter is, these flow meters have got stops at the bottom and at the top. So this is mainly to see that this bobbin or the float should not get escaped into the hind bar or the back bar. So in order to prevent that, again a safety feature, we have the bobbin stops at the top and then at the bottom. Now you can see this is the float and the bobbin. So what is the principle behind this bobbin floating at a particular level? Again, there are two forces that are acting when you open the gases. So one force is the gravity, because of the weight of this bobbin acting from above, it is trying to push the bobbin down. And the gases, whatever we are using, the flow of gases will also produce a force which is trying to lift the bobbin higher. So when the equilibrium occurs, so the float will start floating, or the bobbin will start floating at a particular level. So the top of the bobbin is the one, this is the upper margin of the bobbin, is the one which will give us the indication of what is the flow, because the scale is there on the outer aspect of the flow meter. You can just know how much of flow. It is not from the middle of the bobbin or from the bottom of the bobbin. It is from the top margin. So other thing you can see here, there are flutes are there on the upper margin of the bobbin. So these flutes are deliberately done, because when the gas starts flowing, it is going to hit these flutes and then it is going to rotate the bobbin. So the rotation of the bobbin is very important. So this rotation of the bobbin also can be seen because of a fluorescent dot that is always present at the upper margin of the bobbin. So even in dark rooms, you can see this fluorescent dot, so that you can, especially in radiology suits, when you're using the anesthesia workstation, you can see the fluorescent dot. And also the back of the flow meters is also has got a fluorescent backing, so that you can continuously visualize the bobbin rotating. So now with modern workstations, we have lights in the flow meter assembly. So you can just put on the lights and you'll be able to see the rotation of the bobbin. So the other thing is, the annular space. You can see the annular space between the bobbin, the outer margin of the bobbin, as well as the inner margin of the tube flow meters. So this space is called as the annular space. So here in the lower flows, the annular space is small. As you go up, the annular space keeps increasing. So the orifice keeps increasing. That's why these are also called as variable orifice flow meters. And the other important thing is that the pressure drop across the bobbin is always constant. That's why these bobbins and the flow meters are also called as the constant pressure flow meters. Now in the modern workstations, we don't have the physical flow meters. We have the virtual flow meters, and both in case of GE machines as well as in Draeger highly advanced workstations. So mainly, we have the virtual flow meters. Here, what you have to do is you have to set the oxygen percentage, and you just set the total flow, and automatically the virtual flow meters, you can visualize how much of flow is there. So the same thing you can also visualize in case of this. That was the CS square machine ISIS. I was showing you this particular slide, and this slide is the Draeger Primus machine. So here also you can set the percentage of oxygen and the total flows, automatically giving you the virtual flow meters how much of flow is there. So I was talking to you about the annular space. So this annular space is between the upper margin of the bobbin and then the inner margin of the flow meters. And here I am depicting as an equivalent channel. So this equivalent channel is much smaller in lower flows and larger in higher flows. So in the lower flows, you can just see the height of the space is much longer when compared to the width. That's why the flow here is the laminar flow or the tubular flow, because it's a tube here. And as you go up in the flow meter for higher flows, the length of this is much smaller when compared to the width of the annular space. So it is like an orifice. So here the flows is orificial. So one thing you should realize, the orificial flows are always turbulent, the tubular flows are always laminar. So that means for low flows, it is laminar flow. For higher flows, it is turbulent flow. Again, why should you know about this? So when you are using the low flows, because it is a laminar flow obeys Hagen-Poiseuille's law, and Hagen-Poiseuille's law is the flow is inversely proportional to the viscosity. So since the viscosity doesn't alter with the altitude, the flows will remain whatever the flow you are set as far as the low flows are concerned. So when you are setting in higher flows, so because the flow becomes turbulent or orificial, and the flow is inversely proportional to the square root of density. So since the density alters in high altitude area, so suppose if these flow meters are calibrated at 760 millimeters of mercury, and you take this machine to a high altitude area, what will happen is, because the density is less, the flow will be much higher than what you think you are giving. So that's the reason you have to calibrate these flow meters for that altitude only before using. So one more question you will be asked about the sequence of flow meters. Again, this is very important. Nowadays, it is the machine standards say that the oxygen should always be the most downstream of all the gases. That is the Eger's sequence of flow meter. So suppose, let us say that oxygen is upstream, the nitrous oxide is downstream. I'm showing you in this first, the diagram. Suppose if there is a break in the air flow meter, then the oxygen will start flowing out, and the patient may be getting more of nitrous oxide, and a hypoxic mixture can be delivered. So suppose if oxygen is downstream, so then even if there is a break here, so nitrous oxide will be flowing out, but patient will be getting enough of oxygen, and it is going to prevent any hypoxic mixture being delivered. So the sequence of flow meters again is an important exam question you will be asked about. Now coming to the back bar or the hind bar, where we have the vaporizers. So again, these vaporizers, again, we have the safety measures. I'm not going to discuss in detail about the vaporizers as such. So these have selector tech vaporizers. So you can select only one vaporizer at a time. And also we have the electronic vaporizers are also there, like Aladdin cassette vaporizers. And we have Flu Eye vaporizers are also there. These electronic vaporizers are very accurate, and the electronically controlled the outlet pressure will be there. And there's a magnet inside which will recognize what kind of what particular cassette is being introduced. So this is an entirely different chapter which will be discussed probably in other lectures regarding the vaporizers. So after the back bar, what we have in majority of the older anesthesia machines and also modern GE machines, we have a check valve and a pop-off valve. So this check valve is again important. So whenever we start ventilating the patient, a back pressure is also created. So if this back pressure, if there is no check valve, it can enter into the vaporizers, and the problems of pumping effect and pressurizing effect, they can alter the outlet, concentration of the vaporizers. In order to prevent this pumping effect and pressurizing effect, we have the check valve, which will not prevent the gases to flow back towards the flow meters and the vaporizers. And also we have a pop-off valve. So this pop-off valve will open once there is sudden increase in the pressure to more than 300 centimeters of water pressure. So I've just, I'll show you one of the video how this pop-off.
Now you see, this is the pop-up valve and also a check valve. Both are there in Boyle's basic machine. I'll just show you. So when I block here, how the, whenever the back pressure goes, now I've opened up oxygen. So I'll close the common gas outlet at a pressure of about 300 centimeters once it develops. So the pop-up valve will open and you can see the gases going out. You can hear a hissing noise. So what I have done is I have blocked this. If you can come be close by, can you record that hissing noise? See, I have just closed. You can hear the hissing noise here.
So that's about the pop-off valve. So, and again, I was discussing you about the difference of ventilators in case of GE and the Draeger machines. In Draeger, we have the piston-driven ventilators. They are electrically driven. In case of GE machines, we have bellows ventilator and double circuit ventilators. You require a driving gas of oxygen also here, but here you don't require a driving gas because they are electrically operated. So that is one of the disadvantages with the bellows ventilators. One question you'll be asked: suppose if the pipeline source is exhausted in when you are using a GE machine, so you open the cylinders. So what will you be doing? Will you continue with the ventilation with the mechanical ventilator, or you will go for a manual ventilation? So if you continue with mechanical ventilation, every breath, so whatever the tidal volume that is going to the patient, that amount of oxygen is also utilized for driving these bellows. So that's the reason in case of the GE machines, if there is you are using the backup cylinders, better to go for manual ventilation. So one thing again is there is no actually the safety feature or safety measures between the flow meter assembly and the common gas outlet, even in the modern workstations. So that is the reason if there is any leak here, so you will not know at all, you can still provide hypoxic mixture. So you have to go for the positive pressure leak test or a negative pressure leak test. So this positive pressure leak test, you just pressurize the system to 20 centimeters by using oxygen flush, and see this pressure should sustain for about 10 seconds. So you also open the vaporizers and again check for whether there is any drop in the pressure if there is a leak in the vaporizer. But this positive pressure leak test can only be done for Draeger machines where there are no check valves. So if there are outlet check valves, so you are checking the leak only from the check valve downwards. So whatever, if there is a leak in the vaporizers or in the flow meters, you will not be able to check. So in case of GE machines, you always should go for negative pressure leak test. So in the negative pressure leak test, you have a bulb connected to the common gas outlet. You keep on squeezing it and you drain out all the gases that are present inside. And this, whatever the bulb which is collapsed, should remain collapsed for at least about 10 seconds. Then you know that it is leak proof because there is a check valve is there. So even if after that you can open the vaporizers, because the check valve is there. So because you are creating a negative pressure, this negative pressure leak test is also going to check for any leaks from the flow meter assembly to common gas outlet. That is why this negative pressure leak test can be done both for GE machines and Draeger machines, and it is also called as universal leak test. So in modern workstations, you have automated self-checkout tests. So, but if you have a check valve, it is better to use the negative pressure leak test before going in for the automated self-checkout. So whatever it may be, still hypoxic mixture can be delivered to the patient. That's why you should always have an oxygen sensor at the inspiratory limb, so that you know what is the FiO2 the patient is getting. So this is the most important safety feature that is there in modern workstations. So just to conclude, over the years, the conventional anesthesia machine has evolved into an advanced care station. The new machines use advanced electronics, software, and technology to offer extensive capabilities for ventilation, monitoring, inhaled anesthesia agent, low flow anesthesia, and closed loop anesthesia. But the new solutions to old problems might raise new problems. So we must remain educated, prepared, and vigilant. An oxygen analyzer and a vigilant anesthetist are the minimum mandatory requirements for providing safe anesthesia. Thank you. So I took slightly more time I thank you for allowing me to use the extra time. Thank you so much.
Thank you, sir. I think we'll quickly go on to the next speaker. I request Dr. Girish to start his presentation. And I thank sir for doing a complete coverage of entire aspect of anesthesia workstation. Dr. Girish, kindly start your presentation.
Thank you, sir. Am I audible?
Yes, please.
Yeah.
Thank you, sir. Good evening, everyone. Greetings from JSS Medical College and Hospital. Topic given to me is the failed spinal causes and management. This is one of the most common incident which we come across as a practicing anesthetist. Along with the causes and management, I will be also be telling my experience as a practicing anesthetist since last 10 years. So under these things, I will be discussing today: introduction and history, definition, incidence of failure, causes of failure, management, prevention, salvage the spinal block, repair spinal block, or general anesthesia. Coming to introduction and history, the first spinal itself was a failure. The first spinal was given by August Baer and his assistant.
Your slides are not visible. Is it on, Dr. Girish?
Yes, sir.
You've said somehow I am not able to see your slide. I would like to inquire if anybody else is seeing it, or no problem for my
Slides are not seen. He has to share his PowerPoint.
So share the PowerPoint, Girish.
Can you see now?
Yeah.
Yes.
Yeah.
Go
Now
for
we are
slideshow mode. Go for slideshow mode.
Okay, sir.
You can start from the beginning.
Yes, sir. Yes, sir. So, good evening, everyone. So, greetings from JSS Medical College and Hospital. First of all, I would like to thank Meenakshi Sundaram sir, ASK Pudukkottai branch, and our beloved Gurudat sir for giving me this opportunity. The topic given to me is failed spinal causes and management. This is one of the most common incidents which we come across as a practicing anesthetist. Since this topic was mainly directed towards postgraduates, I will be telling more about theory. Also, I will share my experience as a practicing anesthetist since last 10 years. So under these headings, I will be telling about today. Introduction, history, definition, incidence of failure, causes of failure, in management, prevention, how we salvage spinal, repeat spinal, or general anesthesia. Under these headings, I will be telling about the failed spinal. Coming to introduction and history, the first spinal which was given between August Baer and Hildebrand was a failure. In 24th August 1898, August Baer and Hildebrand injected cocaine into each other's subarachnoid space. So it was a failure. Later they found out it was due to leakage between needle and syringe. The expression given by August Baer was experienced profession, healthy patient, correct technique, single puncture, adequate CSF backflow, effective anesthetic agent. So why did it fail? Capriciousness. Even I didn't know the meaning of capriciousness, and such in the dictionary, it means the things which changes suddenly. So the first panel was a failure. As a postgraduate, we usually master spinal anesthesia 40 to 70 supervisor attempts. So 90% success rate will be there. After 40 to 70 supervisor attempts, the 10% failure which we master during our practice. Spinal anesthesia is one of the easiest technique to perform and get adequate result. Even in expert hand with 10, 15 or 20 years of experience, spinal block may fail. It's an awkward situation, especially when you go for emergency cases, maybe emergency cesarean section, the obstetrician would have been waiting for you, would have washed and want to deliver because of some emergency. It may be fetal bradycardia or some other thing. So if the spinal fails, definitely you'll be in an awkward situation. How to handle with this? All those things, the causes and management, I will be telling one by one. 100 years back, Gaston Laborde said this thing. Two conditions are absolutely necessary to produce spinal anesthesia. One is puncture of dura mater, another one is injection of anesthetic agent to subarachnoid space. How do we define failed spinal? There is no specific definition. According to Hadzik's textbook, spinal anesthesia failure can be defined as a failure if surgical operation cannot be performed without the addition of general anesthesia or alternate regional anesthesia. So this is given in Hadzik's. Once I go through many journals, so this was given in IJA. Spinal anesthesia is considered to have failed if anesthesia and analgesia have not affected within 10 to 15 minutes of successful intrathecal deposition of heavy bupivacaine. Coming to incidence, the incidence varies from 3% to 17%. So it has a huge difference. In some smaller cities, there are failure rate up to 30%. The failure rate is more among unsupervised trainees. What are the causes of failure? It may be broadly classified into unsuccessful lumbar puncture, drugs, solution, and injection errors. In unsuccessful lumbar puncture, so improper positioning, incorrect needle insertion, anatomical abnormalities and obesity, and it may be equipment related. Coming to drugs or injection errors, maybe dose, volume, loss of injected or misplaced injection, inadequate intrathecal spread, ineffective drug action, adjuvant and physiochemical improper, local anesthesia resistance. Improper patient positioning. It may be sitting or lateral. So you may master either in sitting or lateral position. So all of my postgraduate days in Stanley Medical College, we gave lateral position. 95% of the cases were given in lateral position. While since last 10 years, my practice, I am mostly giving in. So what is important is abolishing the natural lumbar lordosis by flexing maximally the whole of the spine, hips, as well as the knees. You can see in this figure, in maximum flexion, the space opens up. In extension, the space will become very narrow. So it may be lateral portion or sitting portion. The failure rate is same. I've gone through many journals. So the failure rate in sitting or lateral portion is almost same. So I prefer to give in sitting position. In this figure, you can see this is the ideal position to give spinal in sitting position. Should give a stool so that there will be a flexion at the hip as well as the knee joint, and a pillow should be given so that there will be proper flexion of the spine. And another thing is, in sitting position, it's easy to identify the midline. In sitting position, there is increase in the hydrostatic pressure in the CSF, which makes the spinal needle placement and fluid aspiration easier. Needle insertion technique. So mental picture of the spinal anatomy and appreciation of laws of should be mastered as we go on giving spinal anesthesia. So most of us will give in the midline. Midline usually will go perpendicular or slight cephalad angulation can be tried to give a spinal anesthesia in the midline. And in case of if ligaments are calcified, interspinous spinous ligaments are calcified, we may go for lateral approach. How do we give lateral? You have to palpate the spinous process, go 1 to 2 centimeter lateral read, and give an angulation of 15 to 20 degree direct towards the midline. Few of my friends during my post-graduation days, they prefer to give lateral portion rather than midline. So it's how you master the technique. So you can give either in midline or lateral. Another one is the Taylor's approach. When you fail with midline or lateral portion, so I have given in Taylor's approach. I was successful to give in Taylor's approach. First, we have to identify L5 S1 space, and we have to identify the lowermost part of posterior superior iliac spine. Go 1 centimeter medial and caudal to posterior superior spine and direct towards the midline. Then comes the needle factors. Thinner needles, greater tendency to deviate, slow appearance of CSF, there are more chances of failure. Size between 18 to 25, they do not affect the success rate. pencil point needles, that is Whittaker needles. Usually, pencil point needles are used to prevent Pdph. The opening will be in the proximal part. In Twinkies spinal needle, the opening will be in the tip, while in Whittaker it will be in the proximal. So, small displacement can cause the injection of the drug into epidural or subdural space. This dura acts as a flap valve. When you aspirate, there will be CSF. When you inject, it may go to epidural or subdural space. Then comes anatomical abnormalities. So you can see the kyphosis or scoliosis is a more common anatomical abnormality which we come across. You can see there is scoliosis. The upper thoracic is directed towards the right side and lower thoracic as well as lumbar, it's directed towards the left side. So this may be highest point of iliac crest. If you go, this may be L3, L4 space. It's very difficult to give spinal to which way it's directed, to direct towards the right side or left side. Other abnormalities of the spine are spinal stenosis, osteoporotic compression fractures, degenerative spondylolisthesis, degenerative disc disease, and ankylosing spondylitis. Ankylosing spondylitis are bamboo spine. Even this case is very difficult for intubation also. The cervical spine will be fixed in a flexion posture. I have, in my practice, I have given 8 to 10 ankylosing spondylitis. For 8 cases, I got through paramedian or Taylor's approach. Other 2 cases, I could not get spinal. Later, we converted to GA using fiber optic bronchoscope. Morbid obesity. So, morbid obesity, day to day, I think we can come across these kind of patients. The problem with this, the entire anatomy is distorted. The skin landmarks, entry point are practically never well correlated with deeper structures. 15 centimeter needle is very helpful in this kind of situation. We usually give it 9 centimeter needle, 15 centimeter needle is very useful in this kind of situation. Coming to perineural cysts. Extradural cysts such as Taurulose organoid cysts, dermoid cyst or cystic pneumomas. These cysts, the thing is that they will contain a fluid. When you put your spinal needle, there will be free flow of cystic fluid. When you inject the drug, it will not go to subarachnoid space because of the lack of connection with the subarachnoid. Then comes dose and volume. Gone through many journals, there is no specific, will tell proper dose can be given. Arvello B et al. Stated that although the lowest possible dose of bupivacaine is recommended to minimize side effects such as hypotension, nausea, shivering, and prolonged stay in the PSU. But this reduced dose may be associated with intraoperative pain and failure of block in prolonged surgeries. So, how to give actual dose? Actual dose is chosen depending on the specific local anesthetic drug used, the baricity of the drug, the patient's age, weight, subsequent posture, the type of block intended, and the anticipated duration of surgery. A fully effective dose should be chosen, and actually the fully effective dose should be deposited in the subarachnoid space, including the dead space of needle and the hub. Density. So, most commonly we use 0.5% heavy bupivacaine for spinal drug injection. Isobaric and hypobaric drug spread is very less predictable. With hypobaric, you can give slight head low and you can get adequate block. If we perform lumbar puncture at L4, L5, most commonly we will perform at L3, L4, L2, L3. If the space is not good in L2, L3 or L3, L4, if you perform in L4, L5, because of natural lumbar lordosis, the drug might deposit it in the sacral part. So, may lead to saddle block. In these patients, so it's preferable to abolish the natural lumbar lordosis by giving flexion at the hip and knee. Loss of injected. So it's firm connection between the needle and the syringe, which is must. If the connection is not firm, we may lose some of the drug and may not get adequate spinal block. So firm connection should be there. Misplaced injection. Anterior or posterior displacement can occur. It can occur while attaching the syringe to the needle, aspiration to confirm free flow of the CSF or force of injection. So among these three, there might be anterior or posterior displacement. Few years back, one of our postgraduate, while injecting the drug, pushed the needle anteriorly. The spinal failed immediately. I told what was the reason for failure and repeat spinal the spinal acted very well. Ineffective drug action is the identification errors. Identification errors is unpardonable. There are incidences where other drugs have been injected in place of bupivacaine. So incidence of tranexamic acid is there where patient could not survive. There is an incidence where tranexamic acid was injected in place of bupivacaine and patient could not be survived. So identification errors should not be done. During my post-graduation days also, instead of bupivacaine, dopamine was injected by one of our senior postgraduate. So immediately BP shoot up to 240 by 130. Heart rate went up more than 200, but nothing happened. After 15 to 20 minutes, patient became normal. Concentration error. Proper concentrate drug should be taken. Loss of potency, cold chain should be maintained properly. In case of bloody tap, alkaline pH of CSF may alter the pK of local anesthetic drug and you may not get an adequate block. Adjuvant and their incompatibility. Usually, more commonly, we use buprenorphine or clonidine, maybe fentanyl as an adjuvant. If we mix two opiates or opiate plus clonidine, local anesthetic with ketamine, local anesthetic midazolam, or local anesthetic with adrenaline, they may not be proper physiochemical incompatibility. So there are chances of failure. We did a study on two opiates where we injected fentanyl plus buprenorphine with local anesthetic. Some among 50 patients we did, some 4 or 5 failures were there. Then coming to local anesthetic resistance, it's one of the controversial area. It's an unexplainable, recurring yet unproved. So what are the hypotheses that are proposed? It may be genetic predilection. There is some mutation in the receptors for the local anesthetic drug, especially on the sodium channel. So sodium channel nerve fibers, there will be some mutation. Pathological conditions like Ehlers-Danlos syndrome. With the history of previous scorpion bite, there might be failure. In Indian Journal of Anesthesia, 2013, Pandit Rao et al., they have explained. They did a case control study. So they explained the reason why there will be failure of spinal with a scorpion bite. They said there will be mutation in the receptor. So that might lead to failure in patients who have a previous history of scorpion bite. And finally, patient's factor. So anxious patients, they tend to be very scared. They will be very scared and very uncooperative. Either in the setting or lateral position, the patient has to be exposed. There will be very hypertensive, especially females. So if the patient has already some painful conditions like fracture of the femur or any primary coming with labor pain or any intra-abdominal lesions which are painful, it's very difficult for them to convince. So they might think anesthetist as someone who has come to injure them. So how do we deal them? Very gentle and careful handling of the patient, maximal physical, emotional, as well as moral support. Patience on the part of anesthetist is a must. You should have patience and properly handle them. Humane consciousness as well as caring attitude. That is the need of the hour. So from this image we should take patients to this image. They should be very comfortable and watch cricket match with you. How do you manage? Prevention is always better than cure. How do you prevent? A proper pre-anesthetic evaluation should be done. So proper pre-anesthetic evaluation should be done, especially elective cases. All the elective cases never fail. How? You should take a thorough history. Any previous spine surgeries. They might have undergone some spine surgeries, pedicle screw fixation. They might have put some pedicle screws and rods. Definitely, it will hinder in the path of spinal needle. Any previous history of failed spinal and examination of the vertebral column, especially thoracolumbar spine, should be done to rule out any abnormalities. Kyphosis, scoliosis should be done. If one warrants, imaging studies should be done. It may be X-ray, ultrasound, or CT, if available. Either real-time or pre-procedural ultrasound should be done. In this image, you can see we kept ultrasound probe at L4, L5 space. This is erector spinal muscle, CSF, posterior dura. This is anterior dura. So, if available in operation theater, real-time ultrasound should be used, especially in morbid obese patient. If not available, pre-procedural ultrasound should be used. How do you manage? So, salvage the block, repeat spinal or general anesthesia. How do you salvage the block? So all these choices, that is salvage or repeat or general anesthesia, it all depends on time of onset of failure. If you think the surgery will go for 1 hour, you would have given spinal. If it goes more than 1 hour, spinal might fail. So at that time, you have no other option other than giving GA. If you're given spinal, the surgeon is painting. If the patient tells, still the patient can feel the sensation, or there is motor block, you can go for repeat spinal. And if it is patchy, or if it has come up to T9, or if you want level block up to T8, you can give salvage. You can give some headlock position, or you can give some IV opioids, analgesics, and you can salvage the block. So it all depends on time of onset, the technical difficulty. If it is already a difficult spinal, and you would have taken more than 3, 4, or 5 pricks, so patient will not cooperate for another spinal block, complete block or partial block, and other associated comorbidities. Salvage block. How do you salvage? Before skin incision, slide headlock position, left lateral position with head down, limited hip flexion, Valsalva maneuver or coughing, epidural volume expansion with saline or local anesthetics. If you have put epidural along spinal, you can do volume expansion. After skin incision, you can give systemic analgesia, local anesthesia infiltration, reassurance, and finally, if nothing works, you have to go for general anesthesia. Repeat spinal. If a senior anesthetist, if available, he should perform a repeat spinal. Preferably, it should be given in sitting position. In partial block, if you want to give repeat spinal, the 2 doses should not exceed the single dose which we want to give for that particular patient and particular surgery. What are the advantages of repeat spinal? It is very simple to perform, avoids the complication associated with general anesthesia. What are the disadvantages? Excessive cephalad spread, exaggerated hypotension, high spinal, chances of high spinal and total spinal, high chances of Pdph. If you give multiple attempts, epidural hematoma can occur. If the initial failure reason is some anatomical abnormality, if you repeat, definitely it might fail. And finally, the repeat dose local anesthetic toxicity can occur. Then coming to general anesthesia, Royal College of Anesthetists suggests that in keeping with the best practice, the conversion rate of spinal anesthesia to general anesthesia should be less than 1% for elective cesarean section and less than 3% for emergency cesarean section. This is what they say. What are the disadvantages of general anesthesia? It is the unpreparedness. So we might not have prepared for spinal. We might not have supraglottic airways or intubation gadgets like airways, supraglottic airways. You might not have these things. And difficult airway, especially in morbid obesity and ankylosing spondylitis. Also, if the patient have any thyroid tumor, thyroid anomaly, or intraoral lesions, definitely that may be difficult to intubate. And you should bide time so that if available, you should intubate with fiber optic bronchoscopy. And presence of other comorbid illness. Aspiration risk, especially in emergency surgeries like emergency cesarean section and laparotomy for bowel perforation. Hypotension can occur. There might be sympathetic blockade. There might not be motor blockade or sensory blockade. Sympathetic blockade, if you give general anesthesia, that is inducing agent, there might be exaggerated hypotension can occur. So in 1907, more than 100 years, this is what Alfred E. Barker said. For a successful spinal anesthesia, it is necessary to enter the lumbar dural sac effectively with the point of the needle and to discharge through this all the contemplated dose of the drug directly and freely into the CSF below the termination of the cord. This is what Alfred E. Barker said, 115. It is almost 115 years back. Failure to follow this, that is, enter the lumbar dural sac effectively with the point of the needle and to discharge through this all the contemplated dose of the drug directly and freely into the CSF. So, failure to follow this may lead to cause of spinal failure. With this, I want to thank everyone who are listening to my lecture and also Meenakshi Sundaram sir, Gurudat sir, ISI Pudukkottai branch, as well as today's chairperson. Thank you.
Thank you, Dr. Girish. We'll quickly move on to the next talk. At the end, any questions, we'll take that. Thank you. Can I request the next speaker to start sharing the presentation? Dr. Srilakshmi, kindly share your slides. And start.
Actually, sorry, Chairperson, Dr. Girish should stop screen sharing. Only one
Yes,
at a time, so he has to stop. Still, Dr. Girish's screen is.
Yeah, I'm stopping, sir.
You stop your screen share. Yeah, that's good. Now, Dr. Srilakshmi can share.
Sir, she will present through this system only, sir.
Oh, fine.
She's having some technical problem.
Then you share her the PPT.
Yes, sir. I'm doing sir.
Good evening. Thank you everyone for giving me this opportunity. The topic given to me is post-dural puncture headache. Coming to the definition, the International Society of Headache describes post-dural puncture headache as the headache that worsens within 15 minutes after sitting or standing and improves within 15 minutes after lying down with at least one of the following features. That is nausea, which is the most common feature, neck stiffness, tinnitus, hypoacusia, or photophobia. But for this, a history of dural puncture should be there, and the onset should be within 5 days after the dural puncture and should resolve either spontaneously within 1 week or within 48 hours after effective treatment of the CSF lead, usually by the epidural blood patch. Coming to the onset is often delayed, but usually within 48 hours of the dural puncture. It is rarely more than 5 days, and the usual duration is 1 to 7 days, but have been reported to persist for up to 9 to 12 months also following dural puncture. Coming to the associated symptoms, nausea is the most common feature because of the vagal stimulation. Neck stiffness is usually due to a transient cranial nerve palsies from C1 to C3. Then comes tinnitus and hypoacusia. These are auditory symptoms because there is a direct connection between the CSF and perilymph through the cochlear aqueduct. So whenever there is a hypotension, CSF hypotension, that can be transferred to the perilymph, and that leads to the auditory symptoms, and then photophobia. Coming to the risk factors. The risk factors include both patient factors and procedure factors. The patient characteristics include age, early 20s, and females are more prone than males, then pregnancy, low BMI, a previous history of post-dural puncture headache, a history of headache within 1 week of procedure, and also a history of chronic bilateral tension type of headache. Coming to the procedure details, always the needle size is directly proportional to the risk of post-dural puncture headache. And also cutting needles like Quincke's needles possess more risk than the non-cutting needles such as Whitaker's needle. And also the direction of bevel insertion. Always the risk is twice when the bevel is inserted in a direction perpendicular to the longitudinal axis of the spine. And also the volume of CSF removed, which is directly proportional to the risk of Pdph. It has been stated that if a high volume of CSF as much as 20 to 30 ml is removed, it poses a very high risk of Pdph. And also the experience, skill, or comfort of the anesthesiologist, which is which we can see in multiple punctures. Coming to the pathophysiology, the precise etiology is actually unclear, but it is due to the leakage of CSF, that is approximately 10% of the total CSF volume through the dural hole created by the needle. And if the CSF leak is more than the rate of production of CSF, it can lead to Pdph. Because if the CSF leak is more, there can be CSF hypotension, which even attenuates in the upright position. Coming to the 3 pathophysiological mechanisms of post-dural puncture headache, the first mechanism is because of a continuous CSF hypotension, there can be compensatory meningeal vasodilatation, and this vasodilatation can cause headache. The second mechanism is due to a continuous CSF leak, there can be severe intracranial hypotension, which leads to loss of buoyancy and the support system of the cranial structures, and also dragging of the pain-sensitive structures, which are the dura, bridging veins, venous sinuses, and also the intracranial nerves, which can lead to pain and the cranial nerve palsies. The third one is any altered craniospinal elasticity after lumbar puncture that can lead to a change in compliance. That is, the caudal compliance becomes more than the intracranial compliance, and then can lead to acute venodilatation in the upright position. Coming to the presentation of post-dural puncture headache. The cardinal feature is the postural headache, that is the headache that worsens in upright position. The most common presentation is occipital, that is in 27% of cases, or frontal, or even both. The patients describe pain as a dull aching, throbbing, or pressure kind of pain. Now, the cranial nerve palsy is associated with Pdph. The most common nerve affected is the abducens nerve, causing diplopia because of its longest intracranial course. The onset of diplopia is around 4 to 10 days, and it recurs spontaneously in 2 weeks to 8 months. Then, due to a transient palsy of the ophthalmic branch of trigeminal nerve, frontal pain can occur. And also the neck and shoulder pain or neck stiffness can be due to a transient palsy to the cervical nerves, to C1 to C3. And the cause of nausea is vagal stimulation. Coming to the differential diagnosis of post-dural puncture headache, which can be benign or serious etiologies. The benign etiologies can be any non-specific headache, exacerbation of a chronic headache, that is tension type of headache, which is usually described as a squeezing type of band kind of pain in more in the frontal area. Then hypertensive pain, which is usually presented in the occipital region with the associated high BP. Then pneumocephalus. Pneumocephalus is a little difficult to differentiate from post-dural puncture headache because pneumocephalus also presents as a positional headache. But it will not be resolved with epidural blood patch, and pneumocephalus can be easily identified in the CT scan. Then comes sinusitis. Sinusitis always will be associated with a purulent nasal discharge, associated with that tenderness over the affected sinus, and also usually sinusitis, the symptoms will resolve in upright position. And then spontaneous intracranial hypotension. Coming to the serious etiologies, first one is meningitis. Meningitis is usually associated with fever, leukocytosis, or the meningitis signs will be there, like the nuchal rigidity, Kernick sign, etc. Then subdural hematoma, subarachnoid hemorrhage, preeclampsia or eclampsia in the perioperative period, intracranial hemorrhage, and also any intracranial space-occupying lesions. How to prevent post-dural puncture headache? So the first step in preventing post-dural puncture headache is to go with the smallest gauge needles possible. And for spinal block, pencil point needles of 25 gauge needles or smaller will be better. Then orienting the bevel of the Quincke's needle parallel to the fibers, and also paramedian approach for spinal anesthesia. Other preventive measures include using saline rather than air for epidural insertion, replacing a stillet after lumbar puncture before the injection of local anesthetic. This is of less importance. Then a prophylactic epidural blood patch which is performed after the procedure, but before the headache occurs for a patient, and also a continuous spinal anesthesia. A continuous spinal anesthesia with a catheter, which is not actually used now because of the chance of accidental injection of any other unintended drug into the intrathecal space or chance of high infection or arachnoiditis. Coming to the neuroimaging findings of PDph, include small ventricles, downward displacement or sagging of the brain, engorged cerebral venous sinuses, subdural fluid collection, pituitary enlargement, and diffuse meningeal enhancement. All these features are analogous to the imaging in a patient with spontaneous intracranial hypotension. Coming to the treatment. Once the diagnosis of post-dural puncture headache is made, first we have to explain to the patient regarding the presumed etiology, the anticipating natural course of the disease, a realistic assessment, and also regarding the treatment options available. First, we'll start with the conservative management, which is maintenance of proper hydration, prescription of simple analgesics like acetaminophen, NSAIDs, or opioids. Then bed rest per se has no effect on the outcome, but in many patients, they may prefer to lie supine because sitting or upright posture can aggravate their pain. And abdominal binder raises the intra-abdominal and CSF pressure and may provide some relief, but wearing it is uncomfortable for many patients that is not in general use. Coming to the pharmacological methods, first one, caffeine. Caffeine is a CNS stimulant as well as a cerebral vasoconstrictive effect it has. So single dose of IV caffeine of 250 milligram or oral caffeine of 300 milligram have been shown to relieve mild PDph, but the effect is transient. Then sumatriptan, which is a common medication used in migraine, it is a 5-HT agonist. It also has a cerebral vasoconstrictive effect. Sumatriptan is excreted in breast milk, so it has to be advised that breastfeeding should be avoided for at least 12 hours following the exposure to this drug. Then concentropin or synthetic ACTH and hydrocortisone. These stimulates the adrenal gland and increases CSF secretion and thereby decreases the hypotension, CSF hypotension. Coming to epidural blood patch. Epidural blood patch is, the method is autologous blood injection into the epidural space, which spread both cephalad and caudal. So because of this, there is an increase in pressure in the epidural space, and this increased pressure compressed the thecal sac, increasing the CSF pressure. And this causes an immediate relief of the headache. At the same time, the blood coagulates in the epidural space, helped by the procoagulant effect of CSF. And this occludes a hole in the dura, preventing further leakage of the CSF. This mass effect in the epidural space gradually resolves over 7 to 13 hours after leaving a mature clot in the posterior epidural space. Over the next few days, this clot undergoes fibroblastic activity and collagen formation, further securing the closure of the dural perforation. So the technique includes, it has to be done under full aseptic precautions, and the patient is usually in the lateral position. First, the epidural space is identified either at the level of the original puncture or even one space lower. Another anesthesiologist with full aseptic precautions performs a venipuncture and hands over the blood to be injected into the epidural space. Usually 20 ml of blood is injected and some people use up to 30 ml. The blood is slowly injected into the epidural space till the patient reports a feeling of pressure or pain in the back or legs. After the procedure, the patient is advised to lie flat for at least 2 hours and to avoid vigorous activity or straining for a few days. Coming to the complications of epidural blood patch, the most common complication is back pain, which resolves within 48 hours of the epidural blood patch. Next complication is misplacement of drug, which can lead to spinal hematoma. Then intrathecal injection and arachnoiditis, any other infection, subdural abscess, spastic paraparesis, or even cauda equina syndrome, which all are rare. Coming to the treatment protocol, treatment algorithm, Once the diagnosis of a post-dural puncture headache is made, we have to go further with patient education, reassurance, and supportive measures. Then we do triage by severity. Per se, there is no classification, but we'll ask the patient to rate their intensity of pain in a scale of 1 to 10. If it is 1 to 3, we take it as mild, 4 to 6 moderate, and 7 to 10 as severe. For mild headache, mild Pdph, it can be resolved without any treatment. Coming to if the mild headache is worsening or if there is no improvement within 5 days or is it improving in intensity, then we can go ahead with pharmacological or epidural blood patch. Pharmacological methods include the normal analgesics or even caffeine, sumatriptan, or ACTH or hydrocortisone. Even if it is failing or worsening with pharmacological methods, we go ahead with an epidural blood patch. If it is a severe, that is an intensity of 7 to 10, then we go directly ahead with epidural blood patch. After the first epidural blood patch, if the pain is not resolving even after 24 hours, we can go ahead with the second epidural blood patch after 24 hours. Even after the second epidural blood patch, there is no benefit, or if the pain is worsening, then we have to reconsider the diagnosis. We have to see for other options, other differential diagnosis. And then the last option is, even after ruling out all the other diagnoses, if still we feel that post-dural puncture headache is the diagnosis, we can go for another epidural, the third epidural blood patch under radiological guidance. So this is the treatment algorithm for post-dural puncture headache. Other alternatives of epidural blood patch include a bilateral transnasal sphenopalatine block, which is topically, that is a topical intranasal local anesthetic, typically a 4% lidocaine. That is a cotton tipped applicator, which is soaked in 4% lidocaine. We insert through the nostril till it comes in contact with the posterior wall of the pharynx. The applicator is kept there for 10 minutes, which blocks the parasympathetic activity, that is vasodilatation by the neurons. And once the vasodilatation activity is reduced, the pain will come down. Then the next option is greater occipital nerve block. The mechanism is interruption of the pain transmission to the trigeminal and greater occipital nerves activated by the dural stretch. And DISH 10, that is deep inspiration, hold, and deep inspiration, squeeze and hold for 10 seconds. This is actually an innovative, non-invasive and cost-effective treatment. This is a study which has been done by Ganga Medical Care Center in Coimbatore, which has come up in 2021, which has come out very effectively. They took patients with a confirmed diagnosis of Pdph, and the patient position was supine or lying down on the bed with slightly raised foot end. So the steps in DISH 10 manual include deep inspiration, squeeze, and hold for 10 seconds. So first, the patient was asked to take a deep inspiration and hold the breath. After holding the breath, the patient was asked to squeeze his chest and abdomen together, mimicking straining while passing stools. And the patient was asked to hold this compression for 10 seconds and then release the breath slowly. So the mechanism is, once the patient is asked to take a deep inspiration, there is complete insufflation of the lungs and the diaphragm is pushed into the abdomen. And when the patient is asked to squeeze the chest and abdomen and hold for 10 seconds, there is increase in intrathoracic and intra-abdominal pressures. This increase in pressures can be transmitted to the epidural space, both directly and indirectly. Directly through the intervertebral foramina and indirectly through the vena cava and CSF. At the same time, the thoracic and abdominal veins empty into the valvulus epidural veins due to the increased transthoracic and transabdominal pressure. The combined effect of this is a tamponade effect, which leads to compression of the long dural segments over the dependent area, and also the external compression pushes the spinal CSF back into the calvarium. This leads to correction of the intracranial CSF hypotension, restoration of the CSF hemostasis, and also reversal of the dural drag or stretch, which gives a symptomatic relief. That is a relief of the positional headache and the relief of the associated symptoms due to correction of the dural sac. After this study, it was found that all the patients who underwent this DISH 10 maneuver, there was symptom relief within 24 hours and they could be discharged from the hospital on the very next day. Coming to a few points to remember regarding Pdph, post-dural puncture headache may carry a risk of medico-legal liability. Accidental dural puncture may result in chronic headache and back pain, and the anesthetic procedures with the risk of post-dural puncture headache requires an informed consent. Thank you.
Thank you, Dr. Lakshmi, for finishing in time and a nice presentation. There is no questions in the chat box. Sir, do we have some time for questions from the panelists or somebody? Yes, sir.
Yes, sir. Yes, sir.
You can continue.
Yeah.
Yes, sir.
Sir, it is your discretion.
Yeah. I'll first like to ask Dr. Gurudutt, sir. Of course, sir has completed everything, but many time in our exam, we find difficult that because in our institute we have two machines, both are electronic machines. We have Primus and A7 of Mindray, Dragar Primus and Mindray. They have no idea about the knob. They have no idea. So of course the A7 is a virtual knob. So something like in that line, can you, sir, highlight the pure electronic machine? What are the questions we generally ask the PG students so that they will be aware about, particularly how to set the flow, how to check the hypoxic guard in the thing, because it is purely electronic flow control and electronic gas mixing. So these are some 2-3 questions they ask. So can you please, sir, highlight that? So
in as you said, in these highly advanced workstations, so everything is electronically controlled, and you can definitely on the monitor only, but touch screen is there, and on the monitor only you are going to operate. So you can definitely try to set lesser than the 25% of oxygen. So suppose if I try to set 20% or 21% oxygen, it will not take up. So minimum oxygen percentage, it will take up only 25% and above. So that itself is the test for the checking for the hypoxic guard there. So that is a simple test you can always do. And you cannot give only air. If you are giving, then the problem of 21% oxygen is there. So that you cannot give in majority of these electronic systems with the hypoxic guard is there. So then you have to provide some amount of oxygen if you are using only air.
Yes, sir. Thank you for that. And mainly the other people get confused because the virtual knobs are there. Many of them, when they ask that particularly A7 and some machine, now of course Primus, it is only digital. So correct. Virtual knob, when they ask what is the control of flow here, they will say needle valve. There is no needle valve in those machines. It is only to give you a feel of physical rotation of the knob they have incorporated. And similarly, there will be a virtual flow meter. There will be electronic flow meter which will be mimicking like a glass flow meter. So just to have it that regular feeling of that. So thank you so much, sir. And if anyone has any other question for Gurudutt, sir, we can go ahead, sir.
Then I will ask a clarification. Sir, when the manufacturers fix 25% as a guideline, because minimum 25% is ensured, but they are setting up the alarm limit when the pressure drops by 30. When the pressure drops by 30 psi, they are setting the audible alarm. So even that percentage, when it is a proposed oxygen concentration, when the percentage comes at 30, then the alarm will go up. But we want a minimum of only 25%. So what is the big thing about it? And another point, whatever the safety mechanisms we incorporate, so many safety mechanisms, as it is a touch screen and electronically controlled, once one component fails, we cannot do anything. So I personally feel we should have a standby boils machine even though you have a high-end workstation, or at least a ambu bag, which is usually available in the ward. It should be available in the operation theater, because there's so much of sophistication. I think the anesthesiologists tend to relax, but once there is a failure, it is not a screw and a spanner we can work it. Immediately our hands are tied. We have to stop that. So that message I want the juniors to take up, and your view on that.
No, always one should have an alternate source of ventilation. That is always there. Even you see any of the books, first thing they say that you should have an ambu bag in every OT. So it should be hanging on to your workstation. So, electronics can fail, your machine can fail. So suddenly the patient may go develop some amount of hypoxia. So if you have the ambu bag, you can always ventilate. So another thing I'll always, even about a week back, I was asking one of the students, suppose ambu bag is not there, and that your source of oxygen, both the backup ventilation, backup oxygen cylinder, and also the pipeline is exhausted. So what you're going to do? So then she was telling that, the patient has been intubated, paralyzed. So she was not able to answer. So that is what I have faced such a situation long back. So then you have to, mount to tube ventilation. So expired air ventilation you have to do till you get an ambu bag or a cylinder. That's what, once it had happened to me when I was a postgraduate, I started, expired air ventilation. Fortunately, the patient saved. So these used to be common in those days, but nowadays hardly we encounter such things. But still, an ambu bag as an alternate source of ventilation should always be there. So another question you are asking, sir, the alarms are there at 30 PSI. So, but, still the alarms will be there. But as long as you have even enough of the oxygen source with high pressures, still at the flow control or flow meter level, you can provide hypoxic mixture if you do not have the proportionating devices. So that is why the proportionating devices have been added there, so that you cannot give less than 25% of oxygen to the patient.
Sir, I'll just add 2 points, sir. As Meenakshi Sandana sir was telling that I always used to say, if you have a high-end machine, be prepared with another high-end machine. If it fails, you have only that to do. But fortunately, there are few machines which have come now. Particularly, I will quote this A7, where the moment the electronics fail, there is a pop-up control thing where you can directly take the machine will become pneumatic machine. That is like oxygen and air mixture, which will go through the vaporizer and you can give. But even then, the more advanced machine, people become more relaxed. So we should know what to do when it fails. So thank you, sir. Thank you for the wonderful presentation. And I have one question for Dr. Girish. Actually, not question, it's a comment. Beautifully have enlisted all the reason for failure of spinal thing. But what I would like to highlight for the beginners or the initial, like second year, third year people, what they do generally, see this failure, whatever you have listed, and with your experience with all the senior people who are in there, the failure is not that common. So when they fail, they tend to blame it to this kind of causes instead of refining their technique. So those misplaced needle, half inside the dura, half outside the dura, those things. So I would request everybody, once you fail, please revisit your technique. And then, sir, there was a CSF, it was coming. Yes, CSF may come if you are using a quinky needle and the needle is half outside the dura, half inside the dura, you can get a CSF. But when we forcefully inject a bupivacaine or a local anesthetic, that may go outside the dura. You can have a patchy. So all these kind of problems can be there. You can move the needle after the CSF has been injected. So I will just point out and get Dr. Giri's comment on that, that if you fail, always revisit your technique. Of course, if everything is fine, there can be all the listed thing which Dr. Giris has pointed out. I want your opinion, Dr. Giris.
Definitely, sir. As we go on giving spinal, with the experience, definitely our technique will improve. So definitely, initial days, definitely we will fail because of lack of technique, or over a period of time, we will learn the technique. So maybe after a few years, definitely our technique might be right. And one of the reasons might be these things. So whatever causes I have enlisted is initial practice of this. Even a few years back, I told one of our PG, while injecting the drug, he slowly moved the needle inside. So most of the drug was deposited outside the subarachnoid space. So I told him what was wrong with him, and even I corrected him. So I made him sure that next few days he firmly fixed the needle, the syringe, and there should not be any movement. So with the experience, definitely the failure rate will come down. It's not so much as explained, but definitely, but initial days of your practice, there will be failure. Even I have failed in many, and many of our pitches I have seen they have failed, and it will get corrected with the experience. But once you are very experienced, or maybe after many years of practice, if there is failure, then you should think what has happened, what may be the reason. So one of the reasons we should know. Otherwise, if it is repeated failure, maybe the factors may be the non-maintenance of cold chain, or maybe the potency of the drug may not be there, or expiry date, or something you should revisit. And those most of the things which I have explained are in the initial days of practice. Maybe incorrect drug that they might inject, or these things are, it may be difficult spinal. Even ankylosing spondylitis patient, even after 10-15 years of my practice, even today I feel it is very difficult.
Dr. Girish, I should first congratulate you.
Thank you, sir.
I have seen a highly experienced speaker was speaking in the zonal conference. The topic was failed spinal. What to do next? This is the topic. So the hall was full because what is failed spinal? What to do next? But for 40 minutes, the causes of failed spinal, the speaker was discussing, but he never discussed about the management. But I am very happy because these things will not be given in the book, because most of the time common doubts will be whether we can go for a repeat spinal, everything. But with the clarity, you have discussed everything. But I want to differ in only one point. With increased experience, you said that the chance of failure will come down. No, even with the 30 years of experience or 35 years experience, good flow of CSF, good drug deposited, it may fail. We don't know at that time. Only with our theoretical expertise, we say there may be so many patchy areas may be there, some epidural adhesions will be there, only epidurography will fulfill. So if there is a failure, we have to accept it. We have to educate the surgeon, because the surgeon most of the time, obstetricians, once one failure occurs, they will not call them in a private practice. But we have to educate the surgeons. We know so many reasons we have informed, but it has to be dealt in a surgeon's conference. You have done very well. It will fail. Spinal will fail. Nobody can vouch that I have obtained 100% success with that. It will. We will accept that is anesthesia. That is the reason why we are reading. But I congratulate you the same way that postgraduate also. See, you were ready to face the crisis. Once a Pdph occurs, what is the management? You had the guts to say, if there is a failed spinal, what to do next? Then you have classified it methodically, which the textbook will not give. At the time of incision, if it fails, during surgery, if it fails, when to top up, when to use it, you had a clarity, that is your experience. But it will fail. As our chairperson pointed out, it will be there. We will be searching for reasons, but once it failed, we have to go for the next step. So in that, I was comfortable and happy that you have proved that you were a disciple of Dr. Gurudat.
Thank you, sir. And
majority of the time, sir, what happens is to go for a second spinal, or that is a repeat spinal or not, or just to directly go for GA. So that is always.
Sir, he has informed it very clearly, sir. He has informed it very clearly. But only one point he said, once you go for a repeat spinal, you should see to that the total dose should not exceed the estimated dose. But that will not work out, because if you want to give 3.5 ml of 0.5% pp again, you will inject 3.5 ml. So the second dose itself is a higher. See, we are presuming out of that 3.5, some 1.5 may go in according, that is only that assessment. But be prepared for that ascent of spinal.
Correct. Correct.
So that all he has clearly mentioned. That one word, total dose will definitely exceed. The estimated dose will exceed because the estimated dose we have injected at the first attempt itself. So it will exceed. Again, that is the reason why we have to be a scientific person. See, even though it is said, a best anesthetist will avoid complications, a best anesthetist will manage complications also. Because it is said often, bad surgeons do mistake, but the best surgeons avoid mistake. It is not like that. Mistakes do happen, just like accident. We have to overcome that. You were very clear in that in your mandate. I am really happy.
But during my post-graduation days, our teachers used to tell, complications are bound to happen in anesthesia, but you should know how to handle all the complications. So that is the difference between a good anesthetist and an average anesthetist. So complications are bound to happen. You should know how to handle the complications. And with my experience, most of the postgraduates won't speak with the patient properly. Before giving spinal, they should communicate with the patient. They should tell what they are doing. Most of us, they won't speak properly and they won't counsel. And definitely, most of the patients, especially young females or primary, they will be under they'll be in an apprehensive state. So most of the we have seen they have failed to give spinal.
There is a question actually in the chat box. How many times you can repeat the spinal? Please, you answer it.
Till you succeed. This is an imposition. This is an imposition. Till you succeed, you keep on doing for the same patient. That cannot be answered anyway. See,
Yes, sir.
We need not place him in a dilemma. See, if the second attempt is a failure, you
the question was answered by the question was asked.
Yes, sir.
No, we need not place him in a dilemma. See, it should not
Yes,
be.
sir. Most of the journals where I have seen, they say maximum 2 times, sir.
Yeah, that's right.
If you can repeat, but if second time fails, better you go for general anesthesia. That's what most of the even Indian Journal of Anesthesia, the journal which I put it also gives the same. So, but 2 times is the maximum. This is not given in any textbooks. This is through journal and the discussion which I have concluded.
And one more thing I want to add, sir. If the postspinal headache is persisting, you should go for a CT brain. Because I had 2 cases, even the postspinal headache was not proceeded with the pharmacological means. Cases. So many days with so many medications, it is better to investigate with the CT brain.
Dr. Parisam, your internet is unstable.
Yes, sir. Yes, and today is unstable typing.
Internet is not stable. I
Sir,
think
I have,
you're nearing
sir, ALM, sir, I have one question to this post-dural puncture headache. Suppose a patient was managed with the epidural patch for post-dural puncture headache. For the subsequent surgery, whether spinal is advisable or not. Suppose it is a LSCS cesarean section coming for second cesarean section.
I think, sir, we have taken enough time for discussion, and I would like to thank all the speakers and particularly the organizers for doing such a wonderful event. And we should conclude. And from our end, we say that the topics were beautifully managed, and it is a complete justification to the topics. And I was really happy to see a upcoming junior resident presenting very nicely about a very less known topic. So thank you all, and thank ISA Pudukkottai for giving me this opportunity. And I would conclude the session from this point on.
Thank you, sir. Anyway, our president has raised a doubt about spinal in a post-dural puncture headache. If it is recorded, Pdph is recorded, then for medical legal purposes, it is better to avoid. And if you cannot administer general anesthesia, only spinal anesthesia is indicated, then you inform the patient that it is going to happen. Then you go for 27 gauge needle instead of routine 25. Then try your luck. If it happens, keep the patient, expect a Pdph and manage. Now I hand over the session to Dr. Suresh Kumar, ISA President Pudukkottai.
Thank you, ALM sir. Thank you, Gurudat sir. Thank you, Chairperson, Tripadi sir, Grish sir, and Resident Madam. I now invite our treasurer of our ISA Pudukkottai branch, Dr. David, to host the vote of thanks. Over to David.
Good evening, sir. Good evening to all. On behalf of ISA Pudukkottai, first of all, I would like to thank our academic chairman, Dr. ALM sir, for wonderful academic arrangements. And I would like to thank today's chairperson, Dr. Dependra Kumar Tripadi, additional professor, AIMS, Rishikesh, for sharing his experiences. And extend my thanks to our speaker, Dr. Gurudat sir, and Dr. Giri sir, and Dr. Sri Lakshmi for a wonderful academic session. And also thank other faculties and postgraduates. And I thank Acural and A1 Logics for technical support. Thank you. Thank you all.
Thank you, sir.
Thank you, sir. Thank you.
Thank you. Thank you.
We are leaving. Thank you all.
Shilpa can close.
The meeting. A1 Logics, you can enter the meeting. We will leave. Thank you then.
Sir, okay, I'll end the meeting.